I want to welcome everybody tonight to ASJ's live journal club via Zoom meeting. This is our 10th journal club with this format. I want to thank everybody from the ASJ staff. We have Kylie on tonight, as well as Phaedra. They work very hard behind the scenes to make this all possible. I want to introduce our guest author, Dr. John Hunter, who's the author of the featured article tonight. He is the head of the Labiaplasty Center in New York City and routinely performs female genital surgery in his very busy practice. He's also clinical professor at Weill Cornell Medical College. Dr. Hunter completed his general surgery training at Mount Sinai Medical Center and his plastic surgery at SUNY Health Science Center in Brooklyn. We're also very honored to be joined by our moderator tonight, who is Dr. Frank Lista. He is the medical director and founder of the Plastic Surgery Clinic in Mississauga, Ontario. He is one of only a few plastic surgeons who is board certified in both Canada and the United States. So Dr. Lista completed his plastic surgery residency and fellowship at the University of Toronto and has been in practice over 30 years. He is active at Trillium Health Partners and was chief of plastic surgery at Trillium Health Center for over 10 years. So we're very honored to have both of you on the call tonight. So just to start, Dr. Hunter has prepared some overview slides of the articles, but we expect that you've read them and come with really engaging questions, which we're very anxious to hear. So at the bottom, if you see there's a chat button, if you want to type in your questions, it will go to either the group or one of us privately. And then what we'll do is we'll call on you and you have the chance to ask Dr. Hunter or Dr. Lista your question. And this whole thing will be recorded. It'll be on the ASJ website for your review later. And so with that, Kylie, please, if we can have Dr. Hunter's slides and we'll begin.
Well, thank you, Cindy. It's an honor to be able to briefly present my article that was published now almost 3.5 years ago in ASJ on my experience of, at that time, more than 600 female genital cosmetic surgery cases on labia, mostly Labia Minora cases, but including Labia Majora, Clitoral hood, and other genital cases. And it's really my evidence-based experience. So basically, and next slide, please. Basically, most women who come for these surgeries come because they're really unhappy with the appearance of their genitals. It's really, although there are discomfort issues, and if you read a lot of the literature, particularly from the gynecology side, a lot of issues related to other issues seem to be common. It's really more appearance issues, frankly, that are the issues that we see more commonly in the States, because insurance issues are not usually the issue. Next slide. And especially for people who don't do a lot of this, it really are going to largely see people who are going to be coming for Labia Minora issues. Go back, please. But even though the predominance of women who will be coming into most plastic surgeons' offices will be coming for seeking what they view as the Labia Minora as their common complaint, you really need to really evaluate the entire anatomic region. So you have to look at the Menorah, the Majora, the Clitoral hood, the perineum, and the mons. Next slide. Next slide, please. So in writing this paper, I really wanted to present the three most common basic techniques that were really described at the time. Although there are a lot of iterations of these three procedures. Go back, please. Historically, the vast majority of Labia Minora reduction techniques were really trim or edge excision techniques. Gary Alter really essentially revolutionized changes in the way labia minora reductions were performed by introducing the wedge procedure, which essentially preserved the whoever is not muting, if they could mute, that would be helpful. But he introduced the wedge procedure, which is really a revolution, or a revolution for this procedure, because it was a method that preserved the labial edge. And then Choi and Kim's procedure, which published in 2000 at PRS, the central deepithelialization, was also a procedure that essentially allowed, again, preservation of the labial edge. So in writing this paper, and I've performed all three of these procedures, I really wanted to present my experience with them and present for surgeons, particularly those who haven't done a lot of this stuff, the advantages and disadvantages of them, and to really allow for how these procedures should be able to be used to tailor them to what the patient's actual needs and expectations are. Next slide. So in this table, which is in the paper, it kind of basically offers what the technique is, and again, there's many iterations, you know, W-plasties and all kinds of different ways of doing these. Gary has subsequently altered, pardon the pun, he's altered his wedge to add the extended wedge and other different ways to what the advantages and disadvantages of each. So for the edge excision, it's still basically, and if you look across the, you know, the spectrum of people doing these procedures globally, it is still probably the procedure that's performed most commonly. It is technically the most simple procedure to do, but simplicity is not without its disadvantages, because it's also the one in which you can do really bad things with, like i.e. you can amputate labia really easily with an edge excision technique. It is adaptable to all labia sizes and shapes. And dehiscences, which are really the most common complication, frankly, that occurs with all labiaplasty procedures. Well, with the edge excision technique, in my experience, it not commonly requires revisions. Disadvantages, well, it removes the labial edge, and for some women, particularly in my experience, women of color who very commonly, well, obviously have dark labial edges, but very commonly the labia then become pink and lighter in color as they move closer to the body. And if everything else is dark, you remove the labial edge in these women, you will give them a kind of an odd looking genital anatomy. For me, the most common serious complication, in particularly the way in which this can be done, particularly if you do it in lithotomy, if you over-inject local anesthetic, if you just are not particularly experienced with it, or if you don't follow your markings, you can over-resect, and that is the most grievous complication with this. Edge scalloping is a not uncommon complication. Part of it's related to suture technique. And edge scarring, it's like the Loch Ness Monster. Everybody writes about it. Somebody wrote about it 1,000 years ago. I've done a whole lot of labiaplasties. I've done a whole lot of revisions. And edge scarring, everybody talks about it, but if it occurs, it's extremely rare. The wedge excision is great because it does preserve the labial edge. It is definitely will eliminate the possibility of edge scalping or suturing, and this remote issue of edge scarring. But it is definitely has a much greater learning curve, and wound dehiscences, when they occur with the edge, Mother Nature will let edge excisions close without having to necessarily close them surgically if they're small. That doesn't occur. Mother Nature doesn't close notches. You have to go back and you have to be patient. No matter what the patient says, you have to wait, let them heal, go back 3-4 months later and close them, but you got to close them. If you over resect with a wedge, besides the fact you probably will end up with over tightening, and you may end up with a dehiscence, and you may end up having to go back and do that, you also may end up shortening the introitus, and you also may end up with other issues with labial edge. Central deepithelializations, that procedure, it does preserve the labial edge, and it also, again, eliminates that issue with scalloping or scarring. But you end up with multiple incision lines. You can, because you're kind of pulling the labial edge down, you can kind of thicken the labia. My experience, and I've only done a handful of these, and when I wrote this paper, basically, I had stopped doing them. You can have prolonged edema with them, and because you are essentially de-epithelializing the labia, inclusion cyst formation is possible. It's possible with all of these procedures, but it's much more likely to occur with that. And it's also more difficult to make labia small, particularly in women who want that with very small majora, very low majora. So it's a procedure that, frankly, I wrote about it. I think it's of limited utility. So I think for most people who want to learn how to do this, learn how to do good trim method and learn how to do good wedges, and you'll be well served in labiaplasty. Next slide. So here basically is just you have to learn how to address the clitoral hood if you're going to do these operations with any regularity. And you can address the hood well with, and I'm talking about the hood, not clitoropexies. If a patient needs a clitoropexy, that is a complicated procedure. I don't do them, and I do a lot of labiaplasties, a lot of clitoral hood operations. If someone really needs a clitoropexy, I generally even refer most of those patients to Gary because he really is an expert in that. That is a complex operation, requires real skill and abilities beyond which most people who are an occasional labiaplasty surgeon or even think themselves an expert, really, unless you really have the training and the expertise to start dissecting the corpora off of the pubis and all the rest of that, this is not really where you want to go. But for addressing the clitoral hood, if you're going to do these operations, you need to know how to do it. You can do this easily and very well, whether you're doing the trim method procedures or whether you're doing wedge procedures. Gary addressed his issues with it, and you can see in the figure A, and this was sort of an easy type patient because her clitoral hood folds, her lateral clitoral hood folds sort of just extended right into the labia, and on figure A, on the left-hand side, you can just see, if you're doing a trim, you can just kind of just extend it right into the labia. But if you're going to do a wedge, you can do an extended sort of wedge where you have the wedge, and then you extend it, and you can just do a essentially a extension right into the hood and address it. But one of the common revisions I do for people who don't address the hood and kind of are uncomfortable with it, for people who aren't like this, is to have to address the clitoral hood. So for people who have vertical redundancy of the hood, in other words, the length of the hood is long, you can just do a horizontal excision. I generally do the same way Chris Amori is described and others, a inverted V wedge excision, cephalic to the caudal edge of the hood. And it sort of is described in the figure on the right. What you don't want to do is, whichever way Mother Nature put the exposure of the glands of the clitoris, in this case you can see the glands is not exposed, don't change that. If it's not exposed, leave it not exposed. If it's partially exposed, leave it partially exposed. If it's fully exposed, leave it fully exposed. You really don't want to monkey around with that. Occasionally, if someone's got a really, really, really long clitoral hood that's almost like a male foreskin, you can shorten that by trimming the caudal end of the clitoral hood, but don't do it to the degree that you expose the glands, because you're not going to alter the innervation of the clitoris, but you don't know what you're going to get into with sensation. Next photo, next slide. This is an example of someone who, and I would not be sure how you could do this with a wedge procedure. You can see this is a person who comes and with hyperpigmented, thick labial edges, as well as very clear bilateral lateral clitoral hood fold. So I did this by doing a trim method of her clitoral hood folds, as well as a trim of her hyperpigmented, thick lateral Labia Minora, and got what I think is a good result. Next photo, next slide. This is somebody who has ptotic, redundant, and deflated Labia Majora. Do not even think about injecting this person with fat, Restylane, wherever else you would want to put in it, because you'll then have somebody with this massively bloated Majora. She needs a reduction of her Majora. Next slide. So other folks, Dr. Felicio, my colleague in Brazil, does excisions in the middle of the Majora. I don't. I do everything exactly this way. I make the medial marking in the sulcus between the Majora and the Menorah. The lateral marking is done in the central port somewhere in the Majora. I do the markings with the patient in maximum frog leg position. You don't want to yank open the introitus, so that's the way you do the marking. I do all of these patients. I don't do anybody in lithotomy position. I do them all in frog leg position. And I think, I'm probably in the vast minority of doing that. It's a pain to do it that way, because I do everybody from the side of the patient, not between their legs, but I don't distort anything, and it's just easier for me to do. So this was a Menorah and Majora reduction. I do these procedures commonly. I presented a presentation last year at the Aesthetic Society meeting, where I did a series of 38 cases that I had done over 2 years of combined Menorah and Majora reductions. The complication rates, other than just a transient increased swelling of the Menorah, there's no increased complications, and you can do them safely if you know how to do both operations well. Next slide. So I do the procedures, again, different strokes, different roads. A lot of people do them under general anesthesia. I don't see any reason to do them, even if you're doing confined procedures, unless somebody has, phobia issues or whatever, or occasionally if I do very, very young adolescent women, young girls who have massive labia and they're 12 years old, occasionally we'll do with IV sedation, but I do virtually all of them under local anesthesia with 10 or 20 milligrams of PO Valium, topical anesthetic before doing the injections local. I do them all supine and frog leg. I never do them in lithotomy. Antibiotics are not necessary other than topical antibiotics. In the paper, I realized in reviewing for this that I wrote a 2-layer closure. That was incorrect. It really requires for wedges a 3-layer. Gary talks about a 4-layer closure. I'm not quite sure I completely understand that. I use 4-0 monochrome for the subcutaneous layer and then close either side. So it's at least a 3-layer closure, but you can't do less than that if you don't want to have an unacceptable layer, incidence of wound dehiscence. You have to be absolutely meticulous for your closures, for wedges. Well, you have to be meticulous for everything, but for that you need to be. For the Majora and Menorah procedures, I always do the Majora first. I do a 2-layer closure with 4-0 monochrome for the deep dermis, and then a 5-0 running glycorapide. For my Menorahs, if I'm doing the trim, I use 4-0 glycorapide. If I'm doing a wedge, as I said, I use 4-0 monochrome for the subcutaneous layer, and then I'll use 4-0 glycorapide for the for either side. If you have the clitoral hood issues, perineal issues, that redundant labial tissue posterior to the introitus, you should address them. Serious complications really should be extraordinarily rare with this. Do not over-resect for either the wedge procedure, because if you have undue tension, you're going to have a dehiscence or problems. And if you over-resect for the trim method, you are going to have a disaster, because if you amputate the labia, you're going to have problems. Learn how to do simple ones. Send the other ones to people who know how to do them better before you go down that road. Thank you very much.
Thank you, Dr. Hunter, for that wonderful recap of your article. I want to open it up to Dr. Lista, who wrote the commentary to this article, and see what your thoughts are about the different methods that were described. And, while he's giving his expert opinion, maybe you can feel free to type your questions in the chat box, and then as they come, we'll call on you. So, Dr. Lista, do you have any comments?
Well, thank you. First of all, I'd like to thank Dr. Hunter. John, thank you for this paper. It's a really important paper for our journal and for plastic surgery, not only to share your vast expertise, but also to get this operation or these series of operations accepted not only by other colleagues, but by the greater society as a whole, which is generally been fairly critical of us speaking to have this operation. Maybe we could chat about that a little bit. What I really liked your paper because so many authors are either wedge guys or gals or leading edge excisors, and I liked the idea that you did what you thought was appropriate. I know you've got your advantages and disadvantages, but generally, putting all that aside, what percentage do you think you do of either technique for the labia minora? And really, how do you decide? Like, how do you have that conversation with the patient?
Well, the first statement would be that the overwhelming evidence is that done well, there's absolutely no evidence in the literature, as you know well, Frank, that it makes any difference at all. The results are absolutely equivalent for the overwhelming majority of women. And a lot of this is just absolutely surgeon preference. Plastic surgeons, as you and I, because we both have gray hair, know, plastic surgeons are the masters at trying to take simple things sometimes and making them complicated. So if we can come up with a procedure, we like to do it. Gary's introduction of a procedure was really quite good because there are women for whom preserving the labial edge is important. And in my practice, that is what I kind of do. So for those women for whom and it's mostly women of color, who have everything else is pigmented, their labial edge is pigmented, and then the labia become pink, those are the women I will always sort of recommend for preservation of the edge. There's another cohort of women that their labial edge is a real problem. They're hyperpigmented, they're verrucous, they come in, the thing they say, I don't like the way their labial edge looks. So those women, I would just say, well, I would not do a wedge on them sort of under any circumstance. So in my practice, the majority, 70% or so of the labiaplasties I do are trims. When I do Menorah and Majora reductions, 100% of them I will do trims because I do not want to get into parallel scars. I don't want to have a scar in the interlabial sulcus and then having perpendicular scars and get into wound healing issues. When I'm doing a lot of hood related stuff, I prefer to do trims because again, it's just the wound healing aspects of it, just in my hands, is simpler. I think if you're Gary Alter, he has found an ability to do wedges for everything. And I believe and respect the fact that he can. I think but you and I have been to the rodeo for a while. We've both seen what neophytes trying to do wedges have done with people that a simple trim would have not resulted in some of the bad things. So I think my advice is always to people who do the occasional labiaplasty is that they're probably 9 times out of 10 better off trying to just do a trim rather than, if you're going to just kind of experiment, to do a wedge. That's my advice. So
I want to give some of the participants an opportunity if they would like to ask a question of Dr. Hunter or Dr. Lista. We have a few minutes remaining. I didn't see any questions in the chat box. So I wanted to open it up to the audience and see if there are any questions for one of these two authors, moderator.
Anyone, just jump in, anyone, or write a chat question. But while I've got Dr. Hunter, I want to ask him, is it my imagination, or are we seeing more and more people asking now for labia majora? And the reason I ask is that it was, up until recently, it was sort of taboo to do anything to the labia majora. And I was really excited by your article, and we've done a few of the operations that you described. Do plastic surgeons need to be afraid of that? And how can we, and you've talked about how to stay out of trouble. What are your thoughts about labia majora?
It's interesting because I've always done, like as I said in that paper, and I have been, I've been faulty in not publishing yet the presentation that I did last year at ASJ, at the Aesthetic Society, but I've always done a lot of Majora operations. I think that a lot of plastic surgeons don't point out to women that that's part of their issue. So, you know, I think, I don't know whether it's they don't point it out because they are uncomfortable with doing the operation. You know, it's like, which is first, the chicken or the egg? But there's a lot of women who, you know, it's an awareness issue on both parts, I think. So, you know, I think that we'll see, once there's more awareness of the operation, it's sort of like the way Menorah surgery was 20 years ago. I think you'll see a lot more patients asking for it.
Well, if there's anybody else, we're coming up on the half hour, so kind of last call for questions. We want to be respectful of everybody's time. And let me just take one more look at the chat box here. But doesn't look like there's any. I want to thank our guest author, Dr. John Hunter, for his insight and for his slides on his article, and then Dr. Frank Liska, who is the moderator and commentator for this article, for both joining us tonight for our journal club. We are very honored to have you guys. We will have another journal club next Tuesday, same time, hosted by YAPS. So stay tuned for another article from ASJ. Thank you, everybody.